Hello everyone, welcome to another video of Medicine in 10 minutes or less. In this series of videos, we discuss different topics of medicine in short videos in a summarized way to help you remember the most important points when you prepare for your exams. In today's video, we will talk about cystic fibrosis. We will talk about the most important points that you need to know about this disease and how to diagnose it and how to manage it. So grab your coffee, let's go. Cystic fibrosis is an autosomal recessive disease, a mutation in the genes that code for chloride transport, which affects the cystic fibrosis transmembrane conductance regulator, in short CFTR. This will damage the chloride and water transportation across the apical surface of the epithelial cells in exocrine glands throughout the body. This will lead to the production of abnormally thick mucus, which will cause problems in different organs in the body, as you can see here, in the genitourinary tract, in the lungs, in the sinuses, the liver, the intestines, and the pancreas. They all clog up because of the thick mucus. In the lungs, as we will see in the next slides, this will lead to a decrease in the ability to get rid of inhaled bacteria, which will cause recurrent infections and problems and damage to the lungs. The common clinical picture of this disease will be a young adult with chronic lung disease. The patient will present with cough, sputum, hemoptysis, bronchiectasis, wheezing, and dyspnea. Also, they will have recurrent episodes of infection, sinus pain, and polyps are also common in these patients. In the GIT, patients will have meconium ileus in infants with abdominal distension. Pancreatic insufficiency is also common, and it happens in 90% of the patients, with steatorrhea and vitamins A, D, E, and K malabsorption. They will also have recurrent pancreatitis, distal intestinal obstruction, and biliary cirrhosis. It is very important to remember that the islets are spared in this disease, and the beta cells function is normal until much later in the life of these patients. That is why insulin secretion is not affected. The genitourinary system will also be affected. Men are often infertile, with 95% having azoospermia, with a vas deferens missing. In women, 20% are infertile because of chronic lung diseases that alter the menstrual cycle, and also the thick cervical mucus that blocks sperm entry. Now, how do we diagnose cystic fibrosis? The most accurate test is an increased sweat chloride test. More than 60 milliequilibrium per liter on repeated testing establishes the diagnosis. Genotyping with CFTR is not as accurate as finding an increased sweat chloride level, because there are so many different types of mutations that lead to cystic fibrosis. Arterial blood gas may show hypoxemia and respiratory acidosis. Chest X-ray and CT will show different findings, including bronchiectasis, pneumothorax, scarring, atelectasis, and hyperinflation. As you can see in this CT scan of the chest, you will find signs like tram lines and dilated bronchi, mucoid impaction, and signet ring sign. Now, what about the pulmonary function testing? What will we find in cystic fibrosis patients? Now, before we talk about what we will find in cystic fibrosis patients, let's go through the different results that we will find after performing the pulmonary function testing. Now, we will assess first the forced expiratory volume in 1 second over the forced vital capacity ratio. If it's decreased, then this is called obstructive disease. If it's not decreased or increased, this is called restrictive disease. It is decreased in obstructive because the forced expiratory volume is decreased much more than the forced vital capacity, while in the restrictive disease, both of them are decreased. That's why the ratio stays the same. After that, we should evaluate the DELCO of each disease. In the obstructive disease, if the DELCO is increased, this will go with asthma. If it's decreased, this will go with COPD. With restrictive diseases, if the DELCO is normal, this will go more with chest wall weakness. If it's decreased, then this will go with interstitial lung disease and granulomatosis disease. In the cystic fibrosis patients, we will have mixed obstructive and restrictive patterns. We will have decreased forced vital capacity and decreased total lung capacity, along with decreased DELCO, just like COPD and interstitial lung diseases. Now, what are the common pathogens that we will find in cystic fibrosis patients? These are the 4 most common pathogens: Haemophilus influenza, Pseudomonas aeruginosa, Staphylococcus aureus, and Burkholderia cepacia. Now, as you can see from this chart, Staphylococcus aureus is more common in younger children, and it gets less and less with age, while Pseudomonas aeruginosa is the opposite. It's not as common as Staphylococcus aureus in younger children, and it's more common in adults. And this is very important when it comes to treatment of acute chest infection in cystic fibrosis patients. Now, when it comes to the management and treatment of these patients, first thing is the antibiotic. The antibiotics are routine in these patients as maintenance treatment. We use the same antibiotics for maintenance as that we use in exacerbation of COPD or bronchiectasis. Sputum culture is essential to guide the therapy, and inhaled aminoglycosides are, as a treatment, are almost exclusively limited to cystic fibrosis patients. Inhaled recombinant human deoxyribonuclease or Dornase alpha is used also in cystic fibrosis patients. This breaks down the massive amounts of DNA in respiratory mucus that clogs up the airways. Also, we can use inhaled bronchodilators like albuterol. Vaccination is very important against pneumococcal and influenza. Palivizumab, which is an antibody against respiratory syncytial virus, is also used in these patients. Lung transplantation is used only in advanced disease, not responsive to the therapy previously listed. And last but not least, we have a combination of 2 drugs, ivacaftor with lumacaftor. These drugs increase the activity of the CFTR in 5% of the patients who have a specific mutation. So it's not useful in all patients of cystic fibrosis. Tizacaftor is an alternative. Now, when it comes to the treatment of pneumonia in patients with cystic fibrosis, we have to focus on the age of the patients because this will give us a hint about the suspected pathogen. In young children, the most common pathogen is Staphylococcus aureus, and in adults, the most common pathogen is Pseudomonas aeruginosa, just like we said before. With Staphylococcus aureus, it is usually associated with concurrent influenza infection. Usually, we start with empiric antistaphylococcal antibiotics to save time and to save the patients. The antibiotic is administered immediately and usually intravenously. Cefepime is one of the good options in this case. It provides cover to methicillin-sensitive Staphylococcus aureus and also to Pseudomonas aeruginosa. In some cases, we have to suspect methicillin resistance, especially in patients with history of recurrent hospitalization, recurrent skin abscesses, and concurrent influenza infection. In these cases, intravenous vancomycin is a good option. In adult patients, as we said, the most common pathogen is Pseudomonas aeruginosa, and in this case, ciprofloxacin is a good option. This concludes our video about cystic fibrosis. We talked about the most important points about this disease, how it is inherited, how it is diagnosed, and how it is managed. I hope you found this video useful. Thank you for watching and see you in the next video. Don't forget to like and subscribe to our channel to see the next videos.